you for joining us for today's webinar. My name is Nastasia Walsh. I'm a program manager at the National Association of Counties. I'm going to be moderating today's webinar. This webinar, as most of you know, is part of Stepping Up, which is a national initiative to reduce the number of people with mental illnesses in jails. And Stepping Up is a result of a partnership between the National Association of Counties, NACO, the Council of State Governments Justice Center, and the American Psychiatric Association Foundation. And we received generous support from the U.S. Department of Justice's Bureau of Justice Assistance and other private sponsors to do Stepping Up. So thank you to our sponsors. Before we begin, just a few technical details to make sure that everyone's able to watch the webinar. This webinar is being recorded. It'll be posted on the Stepping Up website under the Toolkit tab for future viewing. You will receive an email tomorrow with a link to the webinar recording as well if you want to share that. Also to the right of your screen, you'll notice there's a control panel, and in this panel there is a questions box. You can use this box at any time to type in questions or send us a message if you're having any sort of technical difficulties. If you're having technical problems, we'll respond to you within that questions box privately to resolve whatever you're having. And then during the Q&A session at the very end of the webinar, we'll be able to address some of those questions that come in. We do have a very large number of people who are registered for this webinar, and so we may not get to all of the questions at the end, but please feel free to submit, and we'll take them as we can, and I'll be sure to pass around all of the questions to our presenters if they're able to get in touch with you about that later. If you wish to have a better view of the presentation, you can click on the small orange arrow in the top left corner of your screen. So as part of the Stepping Up launch, the three partners asked counties to join the initiative by passing a resolution or a proclamation committing to creating a sustainable plan to reduce the number of people with mental illnesses who are in your jails. As of this morning, 445 counties have submitted resolutions to join Stepping Up, which is very exciting. These counties span 43 states and encompass more than 135 million county residents. You can see a full list of all of the counties that have formally joined Stepping Up on the Stepping Up website by clicking on the tab that says The Counties. On that page, you can also download a copy of the template resolution. It's not too late to join Stepping Up, and we encourage folks to continue to join. Just download a copy of the template resolution, give it to your county board, and then submit it to us when you have passed the resolution, and we'll add you to the list of participants and make sure that you're getting all of the email and all of the updates and all the resources that you need to make your efforts successful on the ground. Since this is the first call in our 4 key measures series, I'm going to go over a little bit of background information about what Stepping Up is and the framework on this. So for some of you, this is going to be a review, but we're excited about all of the new folks who have recently joined Stepping Up. So just want you to have a general framework for what Stepping Up is. So as many of you who have been part of Stepping Up for a while know, Stepping Up isn't about endorsing a particular program or a model or a strategy. It's really a framework for helping you to move forward with your goals to reduce the number of people with mental illnesses in your jails. And so to do this, we created the Stepping Up framework, which is the 6 questions county leaders need to ask. The document was released in January of 2017, so last year, to help counties work through this process for creating sustainable change in your communities. And the hope is really that through careful consideration of these 6 questions as a team, we know that not one agency or one organization can do this alone. We'll be able to determine, what we need to have in place to have a systems level impact in your community to meet your goals in a way that increases public safety, applies your resources effectively, and really puts more people on the path to recovery. And so we know some of you have been working on this for a really long time. Others of you are just getting started. The framework is really meant to meet you where you are. So don't worry if you're just getting started or if you're more advanced. This process will hopefully help enhance your efforts. And so you can see the 6 questions there. We did a whole webinar series on each of these 6 questions last year. You can get all of those on the Toolkit website. On Stepping Up, just click on the yellow bars that have question 1, question 2, and you'll see all of the webinars on there. So please feel free to go through those. I'm not going to walk through those 6 questions on this webinar. As the core premise of Stepping Up is to reduce people with mental illnesses in jails, to do that, we suggest that counties focus their innovations on impacting one or more of what Stepping Up calls the 4 key measures. And so these are jail bookings, jail length of stay, connections to treatment in the community, and recidivism. And so impacting one or more of these measures really can help you to meet your Stepping Up goals of reducing your jail population. And so these 4 key measures, as you probably have guessed, is the basis for this series of upcoming webinars, including today. So we're going to talk about key measure 1 today, which is reducing the number of people with mental illnesses who are booked into jails, so stopping folks from even coming into the jail. And keep an eye out for the subsequent 3 webinars on the next 3 measures throughout the rest of this year. One of them is already posted for August 2nd, and so feel free to register for that. So Stepping Up has been very busy so far this year. Last month was Mental Health Month, and it was also the 3-year anniversary of Stepping Up. And so the Stepping Up partners worked with all of you to really raise awareness of this issue and recommitting to doing this important work. And so I want to give you guys a quick summary of some of the activities that we engaged in May. So first, at the beginning of the month, Stepping Up launched a national effort to help counties collect accurate, accessible data on the number of people with mental illnesses who have in your jails. We have a new video up on the Stepping Up homepage that talks about the importance of this particular part of your planning process, and you can also get a copy of the press release on the Stepping Up News and Updates tab on the website. We also have a new 2-pager that outlines this push if you're looking to share it with your stakeholders and talk about sort of this enhanced effort as part of your Stepping Up work. With this effort, Stepping Up is calling on counties to establish processes to systematically identify people who have serious mental illness who enter your jail. The goal is really to have every county collecting accurate, accessible data on these individuals to help inform what you're doing on the ground. And so in order to achieve this goal of identifying folks and collecting data, Stepping Up recommends that counties use the following approach. We want you to establish a shared definition of serious mental illness, or SMI, for your Stepping Up efforts that's used throughout your local criminal justice and behavioral health systems. To use a validated mental health screening tool on every person who is booked into your jail, and then refer people who screen positive for symptoms of SMI to follow-up clinical assessments by a licensed mental health professional, and then record these clinical assessment results and regularly report on this population to your stakeholders. Now, we know this is not necessarily an easy process, and that systems vary in how they, process people coming in and out of their jails. So implementation of this approach will likely look a little bit different in each of your counties so that it best meets your needs and meets the certain circumstances. Some of you, might have your correctional staff doing these screenings and assessments. Some of you, it's your medical or your mental health or your nursing staff who's doing some of this stuff. And that's okay. And we're gonna, share some ways to do that for you. We also know that, jails are really fast-moving environments where people are cycling in and out, sometimes within hours. And so, and asking your staff to do more, often without additional funds, can be really challenging and can take time not only to get a process in place, but also to get buy-in from your staff in order to do those pieces. And so, in recognition of these challenges and the need for counties to see how this works in quote unquote real life, Stepping Up has selected a number of innovator counties to share their experiences and expertise with identifying people who have SMI in their jails, and then gathering and using this information as part of your process. And so we have identified 7 rural and urban innovator counties who were selected as models for their expertise in this area. The 7 inaugural innovator counties include, and you can see them up on your screen here, Calaveras County, California, Champaign County, Illinois, Douglas County, Kansas, Franklin County, Ohio, Johnson County, Kansas, Miami-Dade County in Florida, and Pacific County, Washington. And these innovator counties are really following the recommended three-step approach that I just talked about and demonstrating that this type of data collection is really critical and feasible in counties of all different sizes. So you can read more about each of these counties on the Stepping Up website, and we'll be featuring them on webinars and conference workshops and different resources throughout the year related to Stepping Up. Other counties that are already using or are committed to using this three-step approach are encouraged to contact us at Stepping Up it's info@stepuptogether.org about joining this innovator cohort. We'd love to be able to hear more about what counties are doing in this space and be able to connect you with other folks who are doing this as well. As you all are moving forward with your efforts over the next year, Stepping Up is really going to focus on providing counties with the tools you need in this space. Again, the goal is really to have every county collecting accurate, accessible data on people with mental illnesses in your jail, and then using this data to help connect people to treatment, quantify the scale of the problem in your community, and then identify solutions to track progress on your Stepping Up efforts. So we look forward to supporting you as part of this next push. Continuing our activities in May, Stepping Up also organized a National Day of Action throughout the month of May, but really for May 16th. During the Day of Action, county officials were encouraged to host an event or participate in local activities to share with their constituents the progress they have made in addressing this issue locally. Wanted to raise awareness and understanding of this important issue, and then emphasize their commitment to the Stepping Up process and goals. And so dozens of counties across the country participated in local events to raise awareness, and we're really excited that we had so much participation on that. Really, probably the best way to find all of the good coverage on this is to look at social media using the hashtag on the screen, which is hashtag Step Up for Mental Health, which is the Stepping Up hashtag. So encourage folks to check that out and see what their local communities did as part of the Day of Action and find ways to get engaged through that. And then on May 24th, Stepping Up hosted a workshop at the National Association of Counties Western Interstate Region Conference on the topic of collecting accurate and timely data on people with mental illnesses in jail. The workshop featured 3 of the Stepping Up innovator counties, so Douglas County, Johnson County, and Franklin County, who talked about their process for implementing a robust mental health screening and assessment process and how they're collecting data on these folks. If you missed the live stream, you can still watch the recording on the Stepping Up events page. So just click on the events tab and you'll see it posted there. So great resources for folks going forward and a good primer on what we're doing here. And then finally, counties will be receiving training and technical assistance throughout the year through the Stepping Up Resource Toolkit to help with implementing your own processes for identifying and connecting folks to treatment. On the Stepping Up website, you have access to upcoming and archived webinars. You can download the 6 questions framework and all of the planning tools, review case studies, the latest research, anything that you're looking for on the resources that we've developed are on that page. So would really encourage folks to check that out. All of the resources are of course free and available to help you be successful. So please feel free and share. We also have several activities and opportunities coming up in the next few months. First, next month is NACO's annual conference, which is happening July 13th through 16th in Nashville, Tennessee. At our conference, we have a number of behavioral health and justice related workshops available for anyone who is registered for that conference. So we would encourage you to check out the NACO website that's up on the screen for more information and a full agenda of what we have there, and you can register there as well. And then in August, Stepping Up will host the second of the 4 Key Measures series, which is going to focus on shortening length of stay for people with mental illness. So that's August 2nd at 2 o'clock Eastern, so same time. You can register for that on the Stepping Up Toolkit. And then just a reminder as well, and this isn't up on the screen, but all counties that have passed a Stepping Up resolution are welcome to join our quarterly network calls that are for rural, for mid-size, and for large urban counties. So 3 different phone calls that happen. It's really an opportunity to further network with your peers who are working on these efforts. The next calls are going to be in August, so just email us to join one or more of those networks. And again, those are open to any counties who have passed a Stepping Up resolution. So feel free to email us on that, and make sure that everyone is signed up on the Stepping Up email list to get notifications about the latest resources coming through Stepping Up. Okay, and that brings us to today. So on today's webinar, like I said, we're going to discuss key measure 1 of the Stepping Up 4 key measures. We have a subject matter expert from the Council of State Governments Justice Center, as well as representatives from Pima County, Arizona. Just a reminder, after everyone has had a chance to present, we'll have some time for Q&A. So feel free to submit questions in the question box, while people are presenting, or you can wait to the end if you'd like. But that'll be how we do Q&A at the end. So we're now going to hear from Nikki Smith-Key. So Nikki is a project manager for the Behavioral Health Division of the Council of State Governments Justice Center. And in this role, she provides support to law enforcement learning sites and the Justice and Mental Health Collaboration Program, so JMHCP, if folks are familiar with that. So she works with the grantees whose work focuses on police mental health collaborations in an effort to more appropriately respond to people experiencing mental health crisis. So her presentation is going to focus on some of her work with the Police Mental Health Collaboration Project. So Nikki, the floor is yours.
Thank you, Nastasia, and welcome everyone. Thank you for joining. It's exciting to see so many people on the webinar. If we could go to the next slide. So what we are aware of, I think we're all aware that there's a growing demand for a more appropriate and effective response to persons experiencing mental illness who come in contact with the criminal justice system. We're seeing and continuing to see high numbers. We're encouraging jurisdictions and counties to implement behavioral health diversion interventions as we see this as a logical solution. However, what we're saying to counties and jurisdictions that we're working with, a one-off program or a scattered approach to the implementation of diversion interventions will not give desired outcomes of vast reduction of people's behavioral health needs in the criminal justice system. So we're encouraging those who are passionate about making this change to instead work together as a collaboration for a system-wide diversion approach. We need a holistic, comprehensive strategy that starts by looking at the system as a whole, identifying gaps, current programs, current partnerships, additional partnerships that we should be thinking of, and then developing a strategic plan to address, prioritize, and fund these gaps. So we're encouraging jurisdictions, we're encouraging counties to take a system-wide approach. Agency and system leaders should be aware of the plethora of diversion options that can be implemented throughout a system. What I'm hoping to do is to share with you some models that are currently in place that various jurisdictions are involved in for this more appropriate response. But before I get to that, I want to remind you of the main measure we're discussing for this particular webinar. Next slide, please. So the main focus for today's webinar is to discuss key measure 1, which is to reduce the number of jail bookings to people with mental illnesses. There are a number of sub-measures that jurisdictions should be tracking, should be considering and thinking about to better understand who is entering jail or being diverted from jail, and then comparing that information to the general jail population. Some of the sub-measures that we should be thinking about is the number of mental health calls for service received by the 911 dispatch center. And how are you obtaining that data? You're requesting data from 911 dispatch, or you're also looking to the law enforcement agency for their RMS data. Another sub-measure to consider is the number of people who are screened positive for SMI according to a validated mental health screening tool, which Nastasia alluded to earlier, conducted when booked into jail. And you're requesting this data from the jail and or jail's mental health provider. Another sub-measure to consider is the number of people who are confirmed as having SMI through a clinical assessment at the jail or as a result of data matching with state or local behavioral health system. And you're looking to get this data from the jail or, again, the jail's mental health provider. And the fourth sub-measure to consider is a comparison for these sub-measures to the general population, including demographics and criminogenic information. So we're looking at age, gender, race or ethnicity, offense level or type, and you're requesting this data from the jail. Next slide, please. So as we think through the various outcome measures we should be tracking, let's also think through some questions we should also be considering. Do we have effective police mental health collaborations to divert people with SMI from arrest and connect them to care? Do we have crisis mental health services available and able to respond to calls for service involving people with SMI? What percentage of people with SMI are already under community supervision at booking, and is there an effective partnership between law enforcement and parole and probation? And another question to consider, to what degree are there a set of high utilizers responsible for a large set of jail bookings? Next slide. So what we're talking about today is the goal of diversion and looking at some diversion models. So the goal of diversion is to assist jurisdictions to develop or modify a continuum of responses to people who have behavioral health disorders in the criminal justice system. That includes identification of behavioral health issues, alternatives to traditional case processing, avoidance or reduction of jail time, and linkage to comprehensive and appropriate services in the community. Next slide, please. There are various diversion resources, and these should aim to assist jurisdictions to link individuals in the criminal justice system to essential services that can more appropriately address their behavioral health needs. Arrow down. What are some strategies to preventing behavioral health needs from preventing individuals with behavioral health needs from inappropriately entering the criminal justice system? This is a key question that collaborating partners should be asking. So some of the diversion strategies could include identification and development of partnerships with appropriate criminal justice system and behavioral health agencies or organizations. Identification and developing a criteria for diverting individuals when they first come in contact with law enforcement. We need to also think about a focus on data to properly assess the movement of individuals from behavioral health needs through their systems. Another thing that we can think of in terms of a diversion strategy is tracking the progress by collecting and analyzing data on key measures, as well as making changes to programs, practicing when something is not working effectively. How are we using data to drive practice? There are opportunities for diversion at multiple intercept points, and I know many of you would be familiar with the intercept model. What we need to do is also recognize and the opportunities to divert eligible individuals at different points in the criminal justice system. Next slide, please. For the next two slides, I'm giving you a pictorial representation of the different points in the criminal justice system where we can work at diverting this vulnerable population. As Nastasia said, I work mainly with law enforcement. So what I will be sharing today is mainly at the pre-booking stage, looking at law enforcement, their initial contact with law enforcement, and at the point of arrest as well. Next slide, please. When we're talking about pre-booking, what I will focus on for this particular presentation and webinar are the specialized policing response models, and more specifically, looking at the police mental health collaborations. Next slide. So when we mention or refer to police mental health collaboration, what are we talking about? We're referring to robust partnerships between law enforcement officials and behavioral health care providers. This allows for a more informed and appropriate response to people who have mental illnesses or co-occurring substance use disorders and other vulnerable populations. PMHCs allow for a safer encounter, reduced repeat calls for service, minimizes the strain on agency resources, and connect people with much needed resources. For more information on PMHCs, we'll encourage you to visit the PMHC Toolkit, which is housed on the Bureau of Justice Assistance webpage. Next slide, please. So what are some of the types of police mental health collaboration models or programs? I think many of us who are on this webinar would be familiar with some of these. We are familiar with crisis intervention teams, more commonly known as CIT. We have co-responder models, mobile crisis response team, case management teams, and we have tailored approaches. One thing we must be aware of is that it's important to note that there is no one right type. What we say to jurisdictions that we work with or counties that we work with, you need to assess your needs, assess your gaps, and determine what model would be best for you or what combination of models would be best for you. Next slide, please. So just to go a little more into the individual models, crisis intervention teams, as we mentioned earlier, is most commonly known as CIT, and it's used by law enforcement agencies. It's based on the Memphis model, and many of us may be familiar with this, 10 core elements. It's considered a pre-booking jail diversion program for people in crisis due to a mental illness. The process of addressing system change for crisis care within a community as a whole through intentional coordination across service providers. The recommendation by CIT International to be considered CIT trained, one must complete a 40-hour CIT training curriculum. Individuals should volunteer into a CIT program. 25% of an agency should be trained. What's also important to note is that CIT is more than training. Really important to think about the collaborations that's needed. Really important to think about the community connections that's needed. I can tell you what we're seeing across jurisdictions is that agencies, counties, jurisdictions are doing some revisions to the training curriculum because in some situations, agencies are not able to do the 40 hours. So we're seeing some trainings that are 24 hours or 36 hours. And we're also seeing revisions to the curriculum to provide training for 911 staff and also jail staff. So we're seeing revisions to make them more specific to the entity to be trained. Next slide, please. Another model is the co-responder team. It is specially trained officer and a crisis worker respond to mental health service. The model that we're seeing growing, that's drawing a lot of attention. We're across many jurisdictions. Just recently, we had a visitor from Australia, Canberra, coming to the United States to learn more about the co-responder teams, and they're actually thinking of a trifold model where they would have law enforcement, EMS, and a behavioral health professional be on calls. We're seeing agencies across the United States also doing different variations of co-responder models as well. It draws upon the combined expertise of the officer and the mental health professional. It's a really interesting to be on site, to hear and see law enforcement officers and behavioral health clinicians talk in jargons that are familiar across both. You're hearing clinicians sounding like law enforcement officers and law enforcement officers sounding like clinicians. The team is able to link people with mental illnesses to appropriate services or provide other effective and efficient responses. Next slide, please. Another model which we're seeing and is getting increasing attention is mobile crisis teams. Mental health professionals respond at the request of officers to the scene of calls, and also at the request directly from community members or families and friends. Mobile crisis teams, help to stabilize encounters and assume responsibility for securing mental health services. So once the scene is secure, mobile crisis teams in many situations will take over from law enforcement if it doesn't require law enforcement to be on scene for any longer. This helps and allows law enforcement to return to call for service in a more timely fashion. Next slide, please. Case management approach is something that we're seeing, again, increasingly across jurisdictions and across law enforcement agencies. We do hear and do appreciate that law enforcement officers are not clinicians, and this is by no means what this is. It's not a mental health model. So officers, often in collaboration with mental health professionals, are carrying a caseload of consumers. They engage individuals who have repeated interactions with law enforcement. They work with consumers to develop solutions specific to the individual's need to reduce repeat encounters. This approach strives to encourage individuals to stay connected to mental health services and community resources, adhere to treatment plans and medication regimes, and fulfill other responsibilities such as work, school, or training. I worked with a jurisdiction in California, rural mountainous area, El Dorado County, and what happened is their sheriff's deputies had a caseload to do case management with high utilizers. And again, not a medical model. They're literally calling to say, have you filled your prescription? Have you been to your appointment? Do we need to take you? And within the space of 2 years, they saw a 20% reduction in repeat calls from high utilizers. Next slide, please. And then there's a tailored approach. What we're seeing, and I'm happy Pima County's here. They will be able to talk a lot more about this. We're working with larger jurisdictions like Harris County, Los Angeles County. I work closely with LAPD and Houston PD, and they have a tailored approach. They're using a number of different initiatives to better respond to individuals with mental illnesses. So law enforcement agencies intentionally select various response options to build a comprehensive and robust program. It begins with the expectation that every patrol officer must be able to respond effectively to mental health calls. And it enhances their patrol force with officers or detectives whose primary responsibilities are to liaise with stakeholders and to coordinate criminal justice and mental health resources. So we're working with Madison County PD, for instance, in Dane County. And what we're seeing, they have a mental health officer position available in each of their 5 jurisdictions. They also have mental health liaison, and that's a volunteer position for law enforcement officers on top of their patrol duties, where they help to manage these mental health calls for service that are coming in. And other agencies are doing other innovative approaches as well to better response and to have a more appropriate response for individuals who are experiencing mental health crisis. Next slide, please. What we're also experiencing are jurisdictions that are just not sure what to do or have an initiative implemented, and they need an additional assistance in moving the needle on a more effective response. In response to that, we have been working on developing a police mental health collaboration framework. A fun fact for most of us who are on this call, we might be familiar with this. There are approximately 18,000 law enforcement agencies. We've made a very conservative estimate of possibly 15% employing some level of police mental health collaboration. So we're trying to help agencies, help jurisdictions, help counties to better develop what they have in place, to develop a common framework for all agencies, to help guide fledgling police mental health collaborations or enhance existing police mental health collaborations, all in an effort to help jurisdictions and counties to develop and set themselves up for a gold standard, to provide agencies a standard against which they can assess their programs. Next slide, please. So the police mental health framework is geared towards and is being written with the intention of being a resource for law enforcement executives with the expectations that they can manage up to elected or appointed leaders, horizontally to their behavioral health partners, and down to program level staff and all agency personnel. You will always hear talk about collaborations. It's important that we work together collaboratively to respond to this issue that we're all facing. Next slide, please. So some of the questions that we are encouraging law enforcement to ask and law enforcement need to be asking is our leadership committed to mental health collaboration? Are we following clear protocols to respond to people who have mental illnesses or co-occurring disorders? Are we providing staff with quality mental health and de-escalation training? Do we have the resources and service connections for people who have mental illnesses or are experiencing a mental health crisis? Do we collect and analyze data? And do we have a process for reviewing and improving performance? Next slide, please. So what does this look like for each of these 6 questions? And this is a different 6 questions from your stepping up questions. For leadership commitment, what is it looking like? Is law enforcement leadership supporting the PMHC? Are there interagency work groups? Again, a reminder, we need to be collaborating. Is there funding and resource allocation? Are there ongoing internal and external recognition of the initiative? In terms of protocols, what does it look like? Is there comprehensive, clearly written policies and procedures in place? Are we mapping this process from call for service to final disposition? What does it look like? One thing that we continuously encourage jurisdictions to think about is the information sharing process and putting things in writing. Are there information sharing agreements in place? For many of the jurisdictions that we're working with, there are verbal agreements, but we encourage counties, we encourage jurisdictions and agencies to have an agreement in place so that should in case a member of the program leaves, this is written and enforced. Is staff aware of the policies and procedures? And is there communication and performance review of policies and procedures? In terms of comprehensive training, what does it look like? Are we doing training on knowledge and skills training for all staff? Leaders included, that's very important. Is a training, instruction, and delivery by qualified practitioners and key stakeholders? Is there training aligned with staff roles and experiences? So if we have specialized officers, for instance, are they getting the advanced training that they need? And is there pre and post training evaluation to determine impact and also to make the necessary changes to improve the training that is being offered? Next slide, please. For treatments and services, have we done an inventory of the existing services? Are there programs and services that are operating at scale to meet the needs of the jurisdictions? If we're seeing hundreds of calls for service related to mental health needs and issues, is it sufficient to have one community-based program in place? Do we have enough in place? Are we prioritizing behavioral health resources for the police mental health collaboration and making the case for more funding? For data collection and analysis, and I always stress and analysis, many jurisdictions are collecting data, but what are we doing with this data? Are we identifying measures to be tracked? Is there a process for collecting and reporting this data? Are there mechanisms in place for data sharing? And is there efficient data management system that is in operation? And the last question is the performance measures. And we need to think about, and I do apologize for that last one, the performance measures. Are there, again, data systems, data being collected that can help us to determine whether or not our police mental health collaboration is at scale and whether or not we're doing what is necessary and needed to make the necessary changes to our police mental health collaboration for improvement. Next slide, please. And with that, I will stop for now, and I look forward to any questions that you might have towards the end of the webinar.
Great. Thank you so much, Nikki. Appreciate the presentation. And again, if folks have questions for Nikki, please feel free to start typing them into the questions box, and we'll get to those at the Q&A after we hear from our next speakers. Now I want to introduce our speakers from Pima County, Arizona. First, we have Wendy Peterson. Ms. Peterson is the Assistant County Administrator for Justice and Law Enforcement for Pima County. In this role, she manages the Criminal Justice Reform Unit, which was created to continue to improve criminal justice outcomes while reducing costs and managing appropriate reform programs. Prior to being appointed in this position, Ms. Peterson held roles leading the Human Resources departments in Pima and Pinal counties, as well as serving as Deputy County Attorney in both counties. With Ms. Peterson is Sergeant Jason Winsky. Sergeant Winsky is the supervisor of the Tucson Police Department Mental Health Support Team, which is in the county seat of Pima County. In this role, Sergeant Winsky is also a co-facilitator of the Pima County Regional Crisis Intervention Team training. He's trained more than 1,000 peace officers across Southern Arizona in CIT. He's also a mental health first aid instructor and has certified more than 500 peace officers across Arizona in this training. And then finally, we have Dr. Maji Balfour. Dr. Balfour is a psychiatrist and national leader in quality improvement and behavioral health crisis services. She's the Chief of Quality and Clinical Innovation at Connections Health Solutions, which provides 24/7 access to mental health and substance use care throughout Arizona, and she's also an assistant professor of psychiatry at the University of Arizona. And Dr. Balfour was named Doctor of the Year by the National Council for Behavioral Health for her work at the Crisis Response Center. So welcome to all of you. I'm now going to hand it over to Ms. Peterson.
Thank you, and good morning, everyone. It's still morning here in Tucson, Arizona, where it's still probably over 100 degrees. My name is Wendy Peterson, and as Nastasia said, I am the Assistant County Manager here in Pima County for Justice and Law Enforcement. And we have some really exciting initiatives and programs going on that I would like to talk about briefly, because I'm sure you want to hear from Sergeant Winsky and Dr. Balfour with their specifics. So if you could go to the next slide, please. And that's who's going to be presenting from Pima County today. So let's go to the next slide. That's me. Next slide. family, what we're going to be talking about today, I am going to give you a brief overview of some of the issues and initiatives and programs that we are conducting here in Pima County. And Sergeant Linsky is going to talk about his MIST team at Tucson Police Department, and Dr. Balfour is going to talk about crisis response. Next slide, please. So, Pima County is located in southern Arizona. We're about 80 minutes just north of the Mexican border. Our county is huge. In fact, it is larger than a lot of eastern states, Connecticut or New Hampshire. We've got a population of just over 1 million, and Tucson is obviously the largest town here. But that doesn't really indicate how vast and empty a lot of Pima County is. It's, our slide shows there's approximately 9,200 square miles, but it is a mountainous and desert area with very little water, which provides us with some challenges that we'll talk about in a minute. So we indicate here that it's one of the oldest continuously inhabited areas of the United States, and Native Americans have been here since prehistoric times. We have two tribal nations that are connected to Pima County. The Tohono O'odham tribe is on a reservation that is the second largest in the nation. Our Pascua Yaqui tribe is actually located within our city limits, which is, you know, kind of unusual. But so the Tohono O'odham reservation in particular, again, is a fairly empty, deserty kind of area. So we have a very urban population here in Tucson, but at the same time, our very large county has a lot of rural areas that can provide isolation and difficulties with transportation to get to services, et cetera. I'm delighted that we have this beautiful picture of my hometown with the Catalina Mountains in the background. Tucson is surrounded by 5 mountain ranges and also contains the best Mexican food north of Mexico. Dr. Balfour and I wanted to make sure we told everybody that. We do have 2 jails with a total capacity of about 23, almost 2,400 inmates. Our daily population for our jails runs between usually 1,800 and 1,850. And interestingly and importantly to us, 70 to 80% of those folks are in a pretrial status. So they have not been convicted of anything and frequently are there because they cannot make bail or other reasons that may have to do with income level, et cetera. Next slide, please. So we are part of a Safety and Justice Challenge that is supported by the MacArthur Foundation. We received a grant from MacArthur about 2 years ago. We're in the second part of our second year of our grant, and we're gearing up to reapply for grant monies. But in that time, we have done what I consider to be just amazing work. The first thing is the community collaborative that we have that includes 33 members, and it is a really diverse group of people. We have judges, we have formerly incarcerated folks, we've got service providers, we've got government people, and people who work really, really well together. Within that, we have several different work groups, as you can see here: case processing, we talk about racial and ethnic disparities, and we've got an arrest and charging work group. Along with that, we have a leadership institute that that was funded as part of our grant, and a qualitative study that is being conducted by folks from the University of Arizona, which is just down the street. We work very closely with our pretrial services, which is part of our Superior Court, and have worked to expand screenings for everyone who is booked in the jail, and have implemented and are continuing to implement specialty pretrial supervision caseloads. So another very important thing that we're doing is we're addressing and reducing failure to appear warrants. And we have implemented text and call system reminders, which has really helped with cutting down on failures to appear. One of my favorite aspects of this group is the creation of the weekend and weeknight warrant resolution court events. So folks who can't make it to court during the day or have childcare problems can come over. It starts about 4 o'clock in the afternoon, and they can appear before a judge. They can resolve their outstanding warrants. They can pay fines. Both we do this about once a month at night and once a quarter on Saturday mornings, and that has been just a resounding success. Next slide. So here's our county jail data. You can see that we have a trend of decreasing the population in the jail. We had a fairly lofty goal at the beginning of the implementation of the Safety and Justice Challenge to reduce our jail population to about 1,600 in the next year. While we haven't made that yet, and you'll see this crazy green line just goes up and down, and it pretty much tracks my emotions every week when we get the numbers, but we are slowly chipping away at this number, at least in part as a result of some of the initiatives that we've implemented, and we are hoping to reduce it even further as we get farther along in our Safety and Justice Challenge. Next slide. So this slide is called Building on Momentum, and as it is absolutely accurate, we have a whole lot of support from our county administrator as well as our board of supervisors. Our county administrator tasked us with creating a criminal justice reform unit, which is looking at ways to increase reforms in our community. We have started a housing homeless pilot project, just hired our program director yesterday. This is interesting, especially thinking back on Nikki's seminar topic. We have a jail high utilizer multidisciplinary task force. So we've determined that there are some folks in the jail that keep coming back, and we need to find out why these folks are continue to recidivate. We are working very closely with our public defender to review drug sentencing charges, especially very low amounts of drugs, and what we can do about that. Our county administrator, again, has directed us to start the construction of a pretrial reentry bridge housing facility that is going to be on the grounds of our jail, and we're very, very excited about that. We're starting by using a modular building, and in the meantime, there will be a 2-story building that's going to be constructed next to it. Along with our friends at Tucson Police Department, we are creating a pre-arrest deflection program. TPD is actually starting that on July 1st. We are very, very excited about that and hope, again, that this circles back and relates back to our task with reducing jail population. And we do have centralized data. This is something fairly new to the county, and we work on it and still working on centralizing this. And all those things that Nikki was talking about in terms of data, we're certainly trying to implement now. So next slide. So I'm going to hand this off to Jason Winsky, and he will tell you about his MISS team.
Good afternoon, everybody. My name is Jason Winsky, and I'm the supervisor of the Tucson Police Department Mental Health Support Team. And I'm going to give you a quick overview of how we got to have a team and the basic day-to-day functions of how our team works. Next slide, please. Next slide. So our basic team has a couple of different functions that we do. There's a patrol side to our functions and also a detective side. So what we are at our core is a jail diversion unit. Every interaction that we have on our team, we're a dedicated team that works 7 days a week. We don't do domestic violence calls or burglary calls. All of our interactions are with persons in crisis or with persons who are having some kind of public encounter due to mental illness or being in some kind of crisis. We operate a no wrong door policy in Pima County, meaning my team will take any case that comes into us at any time, whether we know the person has a diagnosed mental illness or not. Next slide. This is the area that my team seeks to work in. Community safety is always at the core of everything that we do. There is an accountability piece, although as we'll talk about a little bit later, we very rarely take someone to jail in my unit. In fact, only once or twice a year. Our main goal is to divert people to treatment and then eventually recovery. Next slide, please. So this is our core functions of why we have a dedicated mental health support team in Tucson and in Pima County. The Sheriff's Department has a team as well in our county. We want to decrease the risk to our personnel. We want to make sure that we're interacting with people in as compassionate and patient way as possible. There's always the component of being responsible with the resources that we have, but ultimately what we're trying to do is break the cycle for people who are in crisis. Next slide, please. So we're going to talk a little bit about how we do that. Of course, we're police officers, so we always make our acronym the best or the biggest, right? So there we are in the middle of the mental health support team, but this is really where we want to protect people when they fall into the gaps of the system, whether it's law enforcement, the courts, probation, the jail, corrections, all of our system partners. We want to make sure that when people fall through the gaps of the system and they end up having contact with law enforcement, that we're directing them to the right place. Next slide, please. So how do we do that? Well, we have two main functions on our team. The first is officers, and very briefly, our officers are in charge of transporting people throughout the community. So they're picking people up on mental health court orders, civil commitment orders. In some places, this is called court order treatment. In other places, this is called assisted outpatient treatment or AOT. So our patrol officers are highly focused on doing those transports from the community to treatment facilities. Our detectives focus really uniquely on follow-up investigations, cases that would normally fall through the cracks of the police department. So suspicious activity, or check welfare calls, people that are maybe not even committing a crime, even a misdemeanor at all, but they definitely came to the attention of law enforcement, and we want to make sure that we're helping them and assisting them however we can. Next slide, please. This is a really kind of unique thing about our team that we're seeing in other places around the nation as well, like at LAPD. One of the biggest innovations that we did is all of the mental health team officers are taken out of the traditional police uniform. And we find that this increases the de-escalation, not just of the person that we're working with, but also the officers themselves. I wanted to mention that CIT training here is actually a really, really core component of everything that we're doing as well. And about almost 80% of our officers on the police department are trained in CIT training as well. Next slide, please. Okay, so this is just a very brief slide that I'll cover in the interest of time quickly. Our Tucson Police Department SWAT team used to respond to barricaded calls for incidents. We used to do a full SWAT team call out for suicidal barricades. We no longer do those. Our mental health support team is responsible now for all suicidal barricades at the police department at a savings of about $15,000 per call. Next slide, please. Okay, I mentioned this already. We talked about how our investigations work. We do a dual investigation, one side for the criminal investigation and one side for a mental health investigation, always in the interest of redirecting the person back to treatment. And lastly, I would highlight for sure a big feature of Pima County is our Crisis Response Center. We really have one of the best in the country, in my opinion. Our Crisis Response Center makes jail diversion possible in Pima County. My team takes thousands of people to this facility a year, so I'm going to introduce Dr. Margaret Balfour, who's going to talk to you about how our Crisis Center works.
Okay, thanks. Thanks for having me. So I'm going to be talking about how our crisis system works together to really tailor our services to make it easy for law enforcement to do the right thing. So next slide. So first I want to start with the structure. And the reason why is because I think it's really important. One of the reasons that our system works so well is because it's built upon a structure that actually allows for accountability and oversight and coordination. So this is Arizona, and we're in the South, and then where that Bearcat or that Wildcat is, that's University of Arizona. Go Bearcats or Wildcats. So we're in the southern region, and Arizona Medicaid is called Access. And so that department then takes all the money from the state funds, Medicaid funds, other crisis dollars, general funds, and they braid all of that money together, and they divide the state into 3 regions, the north, the south, and then Maricopa County, which is Phoenix, is like its own planet. And then they contract with regional behavioral health authorities, which then are at risk for providing those services. And so then they subcontract with hospitals, clinics, crisis facilities, and they oversee the entire behavioral health system, which includes the crisis system. Next slide. And so what this means is that, crisis system, as we were seeing in the beginning presentation, there's lots of many moving parts in a crisis continuum. And this structure allows us to have centralized planning, centralized accountability, and alignment of the clinical and financial goals, because the clinical goals for a crisis system is to decrease ED and hospital use, to decrease justice involvement, while increasing people stabilized in the community and being engaged in care. So not only are those goals that we as clinicians want to see happen, but they also are the more financially less expensive way to treat people. So, next slide. So here's sort of an example of how, can you hit the down button one more time? So here's sort of an example of how you can have sort of a strategic goal that cascades down in our system, all the way down to the state, to the provider on the ground. So one of the goals at the state level is to reduce criminal justice costs for people with serious mental illness. And so the state then tells Access, who is our Medicaid department, that's one of their goals that they need to achieve. So then they, as they're contracting with these Medicaid managed care organizations and these regional behavioral health authorities, they include contract language and deliverables that are aimed at reducing justice involvement. And then it's up to them in their local region of how to achieve that. So our regional behavioral health authority, which is Simpatico Integrated Care, so they then use contract requirements and value-based purchasing, pay for performance type things to incentivize their subcontracted providers to implement the services and processes that you need to reduce the justice involvement. So an example of some of the targeted processes is really many things that are all aligned to treat law enforcement as a preferred customer. Because if we want to keep people with mental illness out of jail, it's the cops who have the patients. And so they're our customers just as much as the patients are. So things that make it easier for them to divert folks to our system is, for example, the crisis line. Some of the 911 calls are warm transferred over to the crisis line, so that keeps the cops from ever being involved. There's a dedicated law enforcement number. If our cops do call the crisis line, they get a supervisor immediately, so they don't have to go through the phone tree and all that kind of stuff. So really just trying to make it easy for them. The mobile teams. So we have crisis mobile teams, including co-responder teams. For just a regular mobile team, if anyone calls them from the community, they have their contract requirement is they're supposed to get there within an hour. But if law enforcement calls, they have a half hour. So that's kind of an example of how things are tailored for them. And there's also targeted programs and services, including things that reach into the jail and try to get their benefits and their outpatient care set up before they leave. Next slide. And so as a result of that, we have a very robust crisis response system, starting with the initial phone calls. So these are the counties that are in the southern Arizona region. You can see we have quite a few mobile teams, including in most counties, or in the more populous counties, they have co-responders as well, which is the law enforcement officer and the clinician together. That whole southern region is very large, so it's 3 times the state of Maryland, basically. And so, as you can see from the data here, about 1,800 activations happen a month. Almost a fifth of them are law enforcement initiated, and they are hitting those metrics. They're responding in about a half an hour. And then when they are able to respond, most of those folks get stabilized in the community. So they never have to go to a crisis center, never have to go to jail, and they get their needs met out in the field. Next slide. Next slide. So if they can't make it, if they can't stabilize them in the community, or if the cop, or if a CIT officer is out in the field and comes upon someone who has a mental health issue, a mental health crisis, or they have someone that they need to engage into services, they bring them to the Crisis Response Center. So this is the facility that our organization manages. It's a really unique facility. It was built with Pima County bond funds in 2011 as an alternative for jails, ERs, and hospitals. They really did a clever thing. They got the whole county together. It passed overwhelmingly, and one of the ways they did that was teaming up with the people who wanted to build like bike trails and stuff, because they figured those folks would vote for mental health too, so it worked. So we see about 12,000 adults, 2,400 kids per year, and it is the major law enforcement receiving center. And when we say no wrong door, we really do mean that. A lot of crisis centers have patients they will and won't take. Like, you ever heard it's easier to get into heaven than a psych facility sometimes? So we don't do that. So we'll take anybody that the cops drop off to us, and we don't have exclusions for they too agitated, too intoxicated, that kind of thing, or their payer. We take anyone who's dropped off to us. We actually want the agitated folks because we would rather have them with us, where we have the facilities and the space and the training and the staff to deal with those people and de-escalate them and not have to put them in some kind of restraints if we don't have to, versus if they go to an ER, they're going to be restrained in the gurney in the hallway, or else they're going to go to jail. So we really do take all those folks. We're open 24/7. We have a walk-in urgent care clinic. So anyone who can walk in, they need their meds refilled, they need to be connected to services. We have the heart of the facility is a 23-hour observation unit. So this is a place where people who are high acuity, so danger to self, danger to others, acutely psychotic, agitated, intoxicated, and withdrawal, these folks, we can have them in a safe and secure environment and have an interdisciplinary team work on getting them treatment started early, getting them stabilized, trying to get them home, developing a good discharge plan for them. And then if we can't get those folks out in 23 hours, we have a subacute short-term inpatient unit for the adults. And then we also transfer to all of the hospitals all around the region. We're staffed with psychiatrists, nurse practitioners, PAs, as well as nurses, social workers, and our peer supports are a hugely important part of our services as well. They do groups on the unit, a lot of one-on-one action with people. It's really meant to be a place for the community to come together and work on getting folks what they need. So there's space built in there for co-located community clinic staff. And over the life of the building, there's been various agencies co-located there, including a peer run that does post-crisis wraparound to help people get connected after they leave us. And it's adjacent to the call center. So the call center that dispatches all the mobile teams is in our building. Right next to us is a very large inpatient psych hospital that's run by Banner University of Arizona, that does most of the civil commitments. The mental health court is right there, so you don't have to haul the patients across town, and then our staff can go testify easily. And then there's a breezeway that connects us to the emergency room. The next slide. And so this is a part in the facility design is really built around making it easy for law enforcement. This whole concept of law enforcement is the preferred customer. When the building was first being built, law enforcement was involved. They were at the table. And one of the things they felt like was if they were going to be bringing people to this mental health facility instead of to jail. They wanted it to be a secure environment. So they have their own entrance. There's this gated sally port. So they buzz a button. It rings this phone that we all have PTSD from, which triggers our staff to know that the cops are there. The door opens, closes behind them. So then if the person were to try to elope, it's a secure place. That triggers our staff to come meet the officers in their own, entryway. And so this just shows like where they bring them. And, before we took it over, we were having a lot of issues where, law enforcement would be walking around, they want to make copies, they need to go to the bathroom, they want some water, and then they'd be walking through the patient care areas, and then we have to ask them to take their guns off. And if you ever ask the cop to take their guns off, they don't like it. So we really said we need to get everything they need right back there. So they have their own restroom, they have their own little office, we have water and stuff for them. And really, they just come in and come out. And if you go to the next slide, we get them out as quick as possible because cops are busy. They have crimes to fight. A lot of them, we have, I think over 80% of our first responders are CIT trained. So they know to bring people to treatment, but they have competing priorities with all of their other calls that they're getting. So we really want to be the path of least resistance. So on a good day, it takes 20 minutes to book somebody into jail. So we need to get the cops out faster. So our target is 10 minutes. So the line with the dots on it shows our turnaround time. And so our median time, we do keep it at 10 minutes or below. The bars are the number of law enforcement drops we get every month. And what's really interesting is the light colored part are voluntary folks. And everywhere else that we've done this, because we've got a place in Phoenix, we've done this in Texas, the cops are always bringing you people under whatever your local civil commitment is, your emergency detention type thing. And I've never seen it like here, where actually 2/3 of who they send us or who they bring to us are voluntary, which means that they're actually going out, engaging with folks and saying, hey, wouldn't you like me to bring you to some treatment? And you want to get some help. So that's a testament to the Tucson Police and the Pima County Sheriff. Next slide, please. And this is what happens to them after they're with us. Well, we are really focused on trying to get, so yeah, we've already sort of done one level of avoiding the most restrictive intervention, which is we've kept them out of jail by having them brought to us. But then next step is we really want to get people their care in the least restrictive way possible. So back to the community if they can, or if they deem to go inpatient, encouraging them to engage in voluntary treatment rather than doing it through the commitment process. So this graph shows all of the people that are brought to us on these emergency applications, like an emergency detention order or Baker Act or 5150, that kind of thing. And that we drop most of those. So some of our core metrics that we track are our voluntary conversion rate. So these are people who, regardless of whether they go home or the hospital, they've converted to a voluntary status. So that's around 70%. And then our community disposition rate, that's the percentage of people that we send to some place, so community-based care, so someplace other than the hospital, basically. And that's ours around 65%. And we do that by getting the treatment started early, getting their families involved, clinics involved, and trying to do what we need to do to get them home. Next slide. Next slide. Yeah, so this is my last slide. And the point of this slide is not to go over each one of these things, but we do recognize that we have a very robust system down here, and it didn't happen overnight. It took a long time, and it took a lot of collaboration. I mean, it's been about 20 years since the first mental health court was started, and then CIT soon after that. And then, we've had, unfortunately, some tragedies in our community, most notably the January 8th shooting with Representative Gabby Giffords. But after that, that was a catalyst for the MIST team to be created. We've got the MacArthur grant and continued to develop data systems and more collaborative systems. And most recently, we've been named as a learning site through the Bureau of Justice Assistance. So I think that's a sort of a validation of the work that we've done. But with that, I will end and hand it back to the organizers to moderate questions. We didn't have time for that, but you can read that. That's us.
Great. Thank you all so much. And the slides are available if folks want to read the story from from the Facebook page about how they worked with someone to make sure that they were getting what they needed. So it's a great story, and I don't want to leave it up here so everybody has a chance to read it. So go back and read it later. So thank you all so much. We appreciate your presentations. I want to turn it over to questions. So we know some folks have already been submitting questions, but if you have questions, go ahead and put them on the questions box. We can go a little bit later just to answer a couple of questions that have come in to do that, but I know some folks have to leave. So thank you for that. So Dr. Belfort, we just had one question that's immediately related to the Crisis Response Center about the capital cost to build it and the annual operating costs, and then how that's paid for.
So the capital, Terrence may know the capital cost to build it because I was not in Tucson at the time. I think it was like 10 million, but I'm not sure. The annual operating costs are a little over 20 million. And so the capital cost came from that bond. And then the operating costs are all of them comes from the regional behavioral health authorities. So that's a combination of Medicaid funds, the STAMHSA block grant, there's state general funds designated for crisis. The county has some crisis funds. And so that's all braided and administrated through the REBA. And then if we have people with private insurance, we will bill that. And a lot of the private insurers, like they don't know what a crisis center is, but once we tell them what it is, they're interested in it, and they do pay for that because they realize that it gets their folks diverted from inpatient.
Mm-hmm. Okay, great. Yeah. And then Sergeant Winsky, can you talk a little bit, so you're with the Tucson Police Department, can you talk a little bit about how you've worked with the Pima County Sheriff's Office on this issue and with the MIST?
Yeah, absolutely. This initiative was really started by the Pima County Sheriff's Department. They had the original mental health support team in Tucson. Ours was created about 3 months later, and we work on cases every day. We have people that live in the county but work in the city and vice versa. We share cases, we share jail data, we share information back and forth. It's a complete collaborative process.
Great, thank you very much. And then we got a question. Nikki, can you just really quickly summarize what the Police Mental Health Collaboration Toolkit is and where you can find that information?
So just a reminder, the Police Mental Health Collaboration Toolkit is a compendium of resources around this issue and this area. So what we did, we put together, there are examples of MOUs, there are examples of business agreements, there's information for behavioral health that is on that website. It can be found at or it's probably easier you put up the that page, Nastasia, if that's easier, or you can find it at https://pmhctoolkit.bja.gov.
Great, thank you very much. And it is on the website is on the slides too, so folks can grab that as well. Okay, so thank you everyone for your questions and thank you for your presentations. I'm going to jump into some polling questions. So we really like to know who's on the call with us, so that it'll help us figure out programming and audience for going forward. So we're going to do a few poll questions. If we can launch the first poll, please. And the first question is about who you are. So you're an elected official, an administrator, do you work for county health or human services departments? This includes providers or people who actually are staff or work with departments, county law enforcement or corrections, any sort of state agencies, and then other, if you selected other, which I know a big chunk of you have, if you want to write in the questions box who you represent on that. So we have a good idea on that. That would be great. That would be really helpful. Thank you. All right, why don't we close out that one and we'll go to the next poll. Great. Thank you, everyone. We're about a third and a third and a third on rural counties, mid-sized counties, and large urban counties. So thank you guys for joining us. And then the last poll, please. And just as a reminder, as you guys are filling out this poll, if you are one of the counties who is, or one of the people who's unsure if your county has passed a resolution, you can see all the list of counties that have passed resolutions on the Stepping Up website, so stepuptogether.org. If you click on the tab that says The Counties, there's a state-by-state list and a map of all of the counties that have joined Stepping Up. So we encourage you to go check that out and see if your county is part of this. And it looks like we have about 26% of you who said no or we're working on it. And on that same page, you can download a copy of the template resolution. Just send us an email if your county board passes that, and we'll add you to the list. We'd really like to have you join the initiative. So please feel free to reach out if you have any questions about that. And thank you to the more than half of you who have passed a resolution who are part of the webinar today. Just a reminder of the upcoming activities. We've got NACO's annual conference that'll have some behavioral health and justice programming. And then the next Stepping Up webinar is going to be on August 2nd at 2 o'clock Eastern, and you can register for that on the Stepping Up website on the toolkit. So please join us for that. Our contact information is available here on the page. Thank you again to our speakers for taking the time to be with us today. Thank you to all of you for participating and for your questions. And for those of you whose questions we weren't able to get to, we will pass those out along to the speakers to respond to you directly if appropriate. We hope to have all of you on future webinars, and please do fill out the follow-up survey evaluation that's going to appear immediately after this webinar concludes. Thank you, and have a good rest of your afternoon.